Thank you, John. Thank you, the Society, for having me here. You just heard and had been demonstrated the way how today endoscopic resection is being performed. And 40 miles away from my hospital is Christian L. working in Wiesbaden. He has done also 1,000 esophageal ER cases. And so the question is now, talking about limited resection versus en-bloc esophagectomy, why do we have limited resections anyway? And I think we were forced a couple of years ago as surgeons to look at alternatives because these endoscopists, they have established quite effective ways to treat early esophageal cancer and Barrett cancer. And so I think there's one question regarding the limited surgical resection in competition with the endoscopic resection and those of variations of surgical resections, for example, transhiatal versus en-bloc esophagectomy. So I would like to address these both types of limited resections that are around in the treatment world of esophageal cancer. You have seen this, and we have to compete with that, and we have to see what patient can deserve this therapy, and how we can split up our treatment options for doing an en-bloc esophagectomy versus maybe more limited resection using the transhiatal approach. This was a discussion for 20 years among esophageal surgeons. And if you look at an international survey from recently, you can see that in those institutions where there is a medium load of cases or a high volume center, the more experienced the surgeons are, the more they choose the more radical en-bloc esophagectomy transthoracic. Now there is a nice randomized trial from the Netherlands showing that you do have somewhat more complications if you go the radical way, and the mortality wasn't different. But the number of harvested lymph nodes was significantly different, and the outcome shows you that both the overall survival as well as the disease-free survival was more of benefit for patients who had the more radical way of transthoracic. So keeping in mind that the mortality was the same, I think it's worthwhile to go, if it's possible in some way, for the radical option of transthoracic. Looking at the quality of life in these patients, you could see that except for after a few months in physical symptoms and in psychological status, there was no difference comparing the more radical en-bloc versus the transhiatal approach. And so this was also true in another study that especially focused on the T3N1 adenocarcinomas. Again, the number of lymph nodes harvested and shows that there is a limited radicality if you do this transhiatal, and it shows you also this can be transferred to the patient in benefit of survival, showing that the more radical approach is better for the patient's survival. Now, of course, you always find in literature, and that reflects the results, that even in a high volume center, if you go the less invasive transhiatal esophagectomy, you come up with a remarkable mortality of these patients. On the other hand, you can see that even in this publication, it was mentioned at the site that 152 patients were done transthoracic. So looking at the outcome, median survival 43 months and 5-year survival in the 40s. There is a comparison with an en-bloc esophagectomy study in high volume centers. These are 9 centers, international centers with more than 2,000 patients, showing that the optimal threshold of lymph nodes that you should remove as a minimum is 23 removed lymph nodes to be radical and to do a good service to these patients with esophageal cancer. Now I would like to come to the second question, more in let's say in competition with the endoscopic approach, using what we do in Europe, or especially in Germany, more the Meredino, that is a Cardia resection and a jejunal interposition, versus what is in America, I think, more favored the vagal sparing esophagectomy. And this first study from Munich shows that you can also limit your complications compared to the more invasive operation by using this very limited surgical resection at the cardia. But this was never followed up really on a big scale and showed any survival data in the long run. If you look at the data from the vagal sparing operation, again, you can also demonstrate with having this limited operation, but only for mucosal cancers, as a competition to endoscopic resection. That is, that your anastomotic problems, respiratory problems, and also the postoperative well-being characterized by the postoperative weight was, of course, less problematic using the limited resection version. But the key point of this all is if you look at the involved lymph nodes. And this is a study focusing on 60 patients with esophageal cancer, early esophageal cancer. You can see in the mucosal cancer, looking at the specimen, none of these had involved lymph nodes. But looking at those cancers that were infiltrated in the submucosa, 45% of these patients had involved nodes. So if they would have been resected endoscopically, the endoscopist would have missed these lymph nodes, and the patient would be doomed for recurrency. And even worse, if these cases would have been done by a limited surgical resection with lymph nodes in the mediastinum not reached by the limited resection like the Meredino, it would also have been missed and therefore would not be radical enough. This is a small study of patients that were operated in Germany as a follow-up of EMR, 16 patients. You can see the staging after the total specimen was seen by the pathologist, showing that 19% the lymph node metastases in the mediastinum in these cases. Also indicating that if you would have just done a cardia resection, so not even esophageal, not even an endoscopic resection, but a cardia resection, having a limited resection, you would also miss usually these nodes in the mediastinum. So therefore, as a conclusion, I think endoscopic resections in the well-defined patients with mucosal cancer is really a very good evolution in the past 10 years by the endoscopists. But if cancers have a submucosal infiltration, it can cause lymph node metastases not only around the cardia or where the tumor is, but also a few centimeters away in the mediastinum that cannot be caught neither by endoscopy nor by limited resections. Therefore, endoscopic resection should be limited to mucosal tumors in the radical treatment. Limited surgical resections without adequate lymphadenectomy should also be limited only to mucosal tumors that cannot be removed by endoscopic mucosal resection. And I think we as surgeons have to work on improving the transthoracic radical approach, and there are a few things that can be done to improve also this operation. Of course, patient selection, doing a lot of these patients, maybe splitting the operation, what we currently do in risk patients, and also using in almost all our cases minimal invasive approach. Thank you very much.